Today's topic is abdominal or belly pain. Abdominal or belly pain is a very diverse and great topic in medicine, and sometimes a very difficult problem to solve. Most of us would have had a relative or a friend who presented to the doctor with abdominal pain, and sometimes faced with the doctor's assessment asking you almost about 20 to 30 questions before even started to examining you. You sometimes ask the question, why is he or she asking so many questions without even getting to examining the belly? The reason for this is because abdominal pain is such a difficult diagnosis at times that you need to find out as much as possible, and as a patient you should be prepared at most times to give the doctor as much information as possible in order to have the best and the fastest diagnosis of abdominal pain. Abdominal or belly pain, as we commonly know it, is a very, very common presenting symptom for a patient visiting a physician in our Richmond Hill practice. It is very common in the Indo-Caribbean and the wider cross-section of the West Indian community. A lot of these symptoms are based on a simple fact of sometimes the food we eat creates a lot of problems to do with the digestive system. But when we put the digestive system aside, the digestive system being from the mouth to the way to the esophagus, back of the throat to the esophagus, then as we enter into the stomach through the esophagus, into the stomach, then we go through the small intestine, this convoluted stuff here, which is almost about 22 feet long, then into the larger intestine, through the rectum, out through the anus, and that is our digestive system. What most of us sometimes forget is that the pancreas is also part of the digestive system, and portions of the liver that secretes the digestive juices is also part of the digestive system. What actually causes belly pain? Here again, we have to try and break it down in terms of what are the common causes of abdominal pain. And here again, it's always going to be by the same method for the physician to be able to elucidate your symptom. It is going to depend on a thorough history. The history is based on where is the pain. Let us divide your abdomen again into 4 quadrants. If we divide it like this, and across like this, we're faced with the right upper quadrant having the liver and the gallbladder and the distal portion of the stomach. This portion of the stomach will form the part of the left upper quadrant, involving the body of the stomach, the antrum of the stomach, and the fundus of the stomach. They're all given different names, and basically they're given names for a particular reason. The middle portion of the stomach, or the epigastrium, which is around the belly button, most of the symptoms from that comes from the small intestine, and it's really diffuse and never, at most times, never localized. Pain in the right lower quadrant here involves the cecum, or the first part of the gut, or the first part of the colon, or the large intestine. The middle portion of the small intestine also forms the lower part of the belly, and the left lower quadrant pain is pain that involves the distal portion or the end portion of this large intestine, the rectum, and the anus. Let's go first and start describing from the very top what is the right upper quadrant pain. Right upper quadrant, as we can see here, involves the liver, the gallbladder, the end portion of the esophagus, the first part of the stomach. So symptoms to do primarily with right upper quadrant pain is, for all intents and purposes, most likely associated with the liver and the gallbladder. The liver in itself is this large organ that is here that basically can become inflamed or infected by the presence of hepatitis A, B, or C, which we'll try and cover in another topic. But beneath it is a common thing, the gallbladder. The gallbladder is that small organ that produces the bile that helps in the digestion of the food. The gallbladder in itself is a very useful organ to aid in digestion. but it also can be a very painful diagnosis if there are presence of stones in the gallbladder. Here again, the presence of stone can be a single stone, which really doesn't need any operation per se, or presence of large numbers of multiple small stones. The issue with multiple small stones within the gallbladder is that they can pass through the bile duct, enter into the common bile duct, which I'm showing you here, and cause an obstruction. When that obstruction arises, it causes an extreme acute right upper quadrant colicky belly pain that can radiate to the back and radiate up to the right shoulder, associated at times with dyspepsia, associated at times with jaundice, if in fact the bile cannot empty the pancreatic duct itself. The issue with that is gallstones is common, but the complication of gallstone is also uncommon unless we happen to find multiple small stones. The issue about that, once the diagnosis of gallstones is made, you and your doctor should be cognizant of the fact of when to say if it's an operation that's needed or not needed. In the presence of fever, jaundice, intractable pain, it's an indication for surgery, but it doesn't mean surgery immediately, because operating on an inflamed gallbladder can in itself produce its own level of complications that we're trying to avoid. The rationale behind this is the pancreas, which lies at the back here. Damage to the pancreas produces enough digestive juices that can cause a problem for the rest of your life. The following discussions we will have, we will try and focus on the stomach and its complications thereof. We will also focus on the right lower quadrant, epigastric pain, and left lower quadrant pain. Good day. Thank you very much. Good morning, ladies and gentlemen. We will continue our topic on abdominal pain. Yesterday, we covered a topic to do with right upper quadrant pain associated with the liver and the gallbladder briefly. Today, we'll try and cover left upper quadrant and epigastric pain. Left upper quadrant pain, as shown in our diagram, is basically pain that's taking place over this portion of the abdomen. This is our right upper quadrant, this is our right lower quadrant, and the left lower quadrant. If we notice here, we have the esophagus, which is the gullet or where we swallow our food that enters into the stomach, and then is actually the bile from the gallbladder secreted into the distal portion of the stomach, and also the pancreatic juices can enter into this portion as well. The stomach in itself, the causes of abdominal pain arising out of the distal end of the esophagus can be related to esophagitis, which is an inflammation involving the distal end of the stomach. In lots of us who tend to put on a little bit of extra weight, the distal portion of the stomach, which is held together by a sphincter, which prevents food having entered into the stomach from going back up into the esophagus, that sphincter in itself can actually become incompetent. When it becomes incompetent, then the food that is already in the stomach then regurgitates back into the esophagus. Why is that an issue? It becomes an issue because once the food enters the stomach, the acid digestive enzymes, the hydrochloric acid, which makes it very, very acid, makes the food in itself irritating to the distal end of the esophagus up here, which then produces a diffuse and a severe epigastric pain. It is important for us to lose the weight so we at least maintain the competency of this sphincter. But in diabetics, we tend to lose control of that sphincter much earlier. And in our population, which is a high percentage of diabetics, this is a very, very common problem in terms of the reflux esophagitis, which is the name of it, which is the food regurgitating into the esophagus and causing an extreme amount of epigastric pain. Sometimes we're faced with relatives telling us that the pain wakes them up at nights at 2 o'clock in the morning. And this is one of the ways that we will try and prevent this kind of symptom from occurring by having small, regular meals, but also trying not to have any food about 5 to 6 hours before going to bed. Also decreasing the portions of our food. Also, we can try and at least be taking an antacid if we know we're going to be waking up at 2 o'clock in the morning to decrease that symptom. Sometimes sleeping on an elevated pillow will also help with that. For us who drink alcohol, alcohol is one of the more mitigating factors that increases that amount of acid that is also being produced. When we look at the causes of belly pain, when we move from the distal end of the stomach, we enter into the distal end of the esophagus, we enter into the stomach here. This is a large organ which we obviously need for storage of our food before it passes into the rest of the gut itself. But within this portion is a large amount of acid being produced, that acid that's only useful if it remains in the stomach. When it leaves the stomach, that acid digestive process has already taken place. But the acid in itself, plus the fact that we produce an excessive amount, also in addition to that, if we happen to be diabetic, and our stomachs are much larger in a diabetic because of something called gastroparesis, it acts on that unexposed stomach for much longer. Here again, we're faced with issues. If the stomach becomes large, a hiatus hernia, which is when the outpocketing of the stomach into the chest wall, can actually cause us to have epigastric symptoms, which also can mimic cardiac disease when it occurs. And hence the biggest single factor in our community is not the fact to do with the peptic ulcer disease per se, or the gastritis, but the fact is when all the ones of us who are prone for cardiac disease have those symptoms, when we do have the cardiac symptoms, which are now life-threatening, we confuse them a lot of times by saying that we have heartburn, we have gas, we are having chest pain because of the gas, and everything becomes an issue of the gas. If we can control those symptoms, when we do have cardiac disease symptoms, then we can actually focus on those and be able to tell our physician, I don't think this is related to acid because I've not had acid for a while. I think it's probably related to my heart because it's on the left side as well. The issues about the stomach per se is, in having peptic ulcer disease, is the complications associated with peptic ulcer disease. But we'll try and cover those in another topic because those will not only involve the older of us, but they also involve the younger members of our population, either because of habit that is increasing the incidence that we have in our community of peptic ulcer disease or gastritis. That is all for now. Thank you. Good morning, ladies and gentlemen. We will continue a discussion on abdominal pain, having completed the discussion on the right upper quadrant, the left upper quadrant. And we said we were going to discuss certain problems with the stomach that is very common in our Indo-Caribbean community. And that is gastritis, gas, peptic ulcer disease, duodenal ulcers, which are basically more or less the same, gastric ulcers, the same symptoms. These are issues that we have with the stomach. And just for the records, in our community, we are probably one of the highest consumers of things like Pepto-Bismol, Mylanta, Prilosec, Nexium, Axid, all the proton pump inhibitors that basically we use for the relief of the acids. A lot of times, sometimes I think simple measures in our community can make the difference. For instance, our late eating at night, sometimes predicated by the fact that we have to work hard for a living, can sometimes be cautioned that if we're going to be eating late at nights, let's at least decrease the portions of food we eat towards the end of the evening and increase the portions towards the midday so the digestive process itself does not take place whilst we are at sleep, presenting with the increased amount of acid in the stomach. Also, a decrease of alcohol intake is something that can decrease the formation of peptic ulcer diseases. In addition to that, also we can try and eat small regular meals, small amount of spicy foods, and at least try and be moderate in terms of our intakes of the rice and roti products, which, even though they do not contribute directly to the production of acid, do occupy a large portion of the stomach, preventing the food from moving forward, and it sits in the stomach producing more and more acid. So by the time we get to bed, we're still producing an excessive amount of acid. If we put on a little bit of extra weight, what then happens is that we then develop an incompetent sphincter, separating the esophagus from the stomach, and that in itself can increase the amount of, because that valve that was there, the valve that actually protects us from the acid going back up to the esophagus, is no longer there. In addition to that, we also, because of the obesity problem that we're having also, we push the intra-abdominal contents, pushes the food from the stomach into the chest wall itself. The issues to do with peptic ulcer disease, per se, in our younger population, in our diabetic population, the older of us, it's basically the stomach itself. Because we lose the autonomic nervous system, the stomach becomes much larger and we're less able to appreciate when it's full. So what we tend to do, we tend to pack it until it becomes completely full. In a diabetic, the stomach itself is sometimes 1.5 to 2.5 times larger than the non-diabetic. Hence, it stores a larger portion of our food. Hence, that portion of the food remains undigested for a larger period of time. When we pack that stomach, which is now a larger portion, we develop abdominal distension, swelling of the abdomen, but that food remains undigested for a while. So instead of the food remaining in the stomach for the 2 to 4 hours that we expect it to do, it remains in our stomach to 6 to 8 hours in excess of that. That food now forms the bloating that we feel. It also forms an increasing amount of acid. It creates a severe amount of discomfort. It makes us feel unwell. We're not able to exercise. We're not able to get off the couch. In general, in a diabetic especially, we should limit the portions of our food because we know our stomach is going to become much larger as we get older. But even in the younger diabetics, gastroparesis, which is when the stomach refuses to want to empty and it remains big and sluggish, is why it is so important for our diabetics to understand that the digestive process involved has been damaged because the nerve endings to the stomach have been damaged, and they do not diagnose, they do not tell us as well when our stomach is full, and hence we tend to pack it with food. Our rice and roti forms the majority of that food that sits in there for a while. And you can ask anyone who has vomited, who is diabetic, who has vomited, they can tell you they've actually vomited food from maybe 24 hours ago. So it is adamant among our population to understand that the stomach is not only a storage organ, but a storage organ that in certain disease conditions, especially diabetics, tend to be bigger. But let's start and figure out what happens in a younger person who basically develops peptic ulcer disease. Peptic ulcer disease is when you have the gastritis that's forming irritation of the stomach, and the acid then acts on the stomach. That acid can act in the stomach, creating a diffuse belly pain that is called gastritis. It inflames the entire stomach wall. The stomach wall is protected by a mucosa and a serosal lining, which prevents the acid from acting on the stomach wall itself, which is when we form peptic ulcer disease or ulcers, it's when we've eroded that protective lining, and now the acid acts on the stomach wall. When it does that, then it's when we develop the complications of peptic ulcer disease. Some of those complications we may have seen in relatives of ours, developing hemorrhage, which means they're bleeding from the ulcer. That bleeding can be frank blood if it's profuse, and we vomit the blood and it shows up bright red blood. In the majority of cases, however, it's a slow ooze, and sometimes we present with black tarry stool or greenish stools to our physician. That is blood that has been altered in the stomach, that has now passed through the digestive system, and it's basically presented as something we call melena. So you can get the hemorrhage from acute hemorrhage to a chronic hemorrhage, both of which can be life-threatening if it's heavy, or it basically can be something that's going to be prolonged. It's going to present with anemia based on the fact the blood system itself loses tremendous amount of blood because the tremendous amount of bleeding can take place on the stomach. The other aspects of obstruction, perforation, and we will try and cover in a subsequent topic. Thank you very much. Good morning, ladies and gentlemen. The last topic we mentioned some of the complications of that can arise from the stomach. We mentioned the presence of gastritis, which is irritation involving the walls of the stomach, and we started to mention hemorrhage, whether it be an acute hemorrhage, that is a large acute hemorrhage when we cough up blood, otherwise known as hemoptysis, or a slow ooze that passes through from the stomach into the small intestine, the large intestine, and then back through the rectum and presents as a green tarry stool, which sometimes make our doctors cringe, but we sometimes wonder why. But it also can be mimicked by taking iron tablets as well. So we should be able to volunteer as much information to our physician when we present with these symptoms. Other most sinister symptoms that arises out of the stomach can be as a result of chronic peptic ulcer disease at the outlet of the stomach. If you have an ulcer at the outlet of the stomach, then the food in itself, what happens here is that ulcer causes a cicatrization or a narrowing of the outlet of the stomach and presents with obstruction. That obstruction now means that the food is unable to leave the stomach. In advanced case or in the early stages, very little food leaves the stomach. When this happens, the stomach becomes bloated, the entire food comes back out, and we are unable to have this portion of the rest of the bowel function for us. The treatment of choice in that case is for removal of that portion of the stomach. The treatment in our community should be to avoid this from happening by treating the peptic ulcer disease early o'clock, either by diagnosing it early and treating it early. Other things that can occur in the stomach is penetration. The ulcer in itself, the gastric ulcer which is here, penetrates into the mucosal wall through the stomach. Then what it does is penetrate into the pancreas. That can produce an intractable, severe belly pain that basically radiates to the back and presents with an extreme feeling of being unwell, associated with vomiting and inability to even tolerate any food. The other things that can happen is perforation, as I mentioned, and penetrating into the stomach, into the pancreas itself. The other issues with the stomach that are complications that can arise is the enlargement of the stomach, the hemorrhage, the obstruction, the penetration. In the older population, we should always be cognizant of the fact that there's an increased chance of gastric cancer. So ulcers can be treated, yes, by medication. First of all, trying to prevent them by being cognizant of the symptoms we're having and trying to prevent them by our diet, a dietary modification, and our habits as well. Dietary modification in terms of the smaller quantities of the food and also the foods that are irritant to the stomach itself. Be also prepared to be taking things like Pepto-Bismol as well to decrease that amount of acid within the stomach. Here again, that is only temporary, it's only brief as well. There are other medications which are sold, proton pump inhibitors, that decrease the amount of acid that's produced by the stomach, and that in itself decreases the symptoms. Our hope here is that we do not allow ourselves to have active ulcer disease because we try and diagnose it early. So most of the medications out there that are newer medications actually not only decreases the acid but increase the healing of the ulcer, and your aim is to heal the ulcer, decrease your symptoms, and prevent it from occurring again. We also going to try and avoid the larger portions of food, sticking to smaller portions of food, avoiding alcohol at all costs, avoiding a lot of spicy foods, especially towards the end of the night. And also be aware that in our special population, in our diabetic population, they're much more prone for these symptoms to occur. We also have to understand that if we start to present with greenish stool, that is a sinister symptom. That should be treated by going to your physician immediately or to the hospital, especially if those symptoms are associated with dizziness, feeling weak, and a feeling of lassitude or lifelessness. That indicates that there's an ulcer that is bleeding, and the bleeding is now starting to affect you in terms of the amount of blood being perfused to the brain itself. So in terms of peptic ulcer disease, the time you start, or gastric ulcer or gastritis, the time you start to worry, and worry significantly to go to your doctor, are when you have the symptoms as follows. If you have persistent pain, intractable pain, pain that radiates to the back, the presence of hemoptysis, which is vomiting of blood, and not large portions of blood, you don't wait for that time to occur, or passing of melena or dark tarry stools. Those are indicative of an ulcer that's bleeding or an ulcer that's penetrating. That's all for now, ladies and gentlemen. Thank you. Good morning. We'll continue our discussion on abdominal pain. Having covered the different quadrants of the abdomen, we're down to the right lower quadrant. The right lower quadrant, having divided the abdomen into 4 parts, involve, according to this diagram, the cecum, which is the first portion of the large intestine. But it also involves the distal portion of the small intestine. We also have the appendix, which is the outpocketing of that portion of the cecum. That's here, that's appendage that sometimes, and a lot of us have given us problems with relatives with acute appendicitis. And we also have the ileocecal valve here. Those being the most prominent things that can give us issues. The portions of the proximal end of the large intestine, the distal end of the stomach, the distal end of the small intestine, the appendix, but also in males especially, things to do with, organs to do with the prostate and also the urinary bladder can be presenting symptoms and confusing symptoms at times. And in the females, also things to do with the urinary bladder, the uterus, the ovaries, the tubes themselves can be signs and symptoms of disease processes that can sometimes mimic abdominal processes. So here at the right lower quadrant, we can become confusing at times as to what is coming from the abdomen, what is coming from the pelvis. What are some of the common things that affect the right lower quadrant pain? And right lower quadrant pain is when the patient complains, "Doctor, I'm having pain on the right lower quadrant of my belly." We've all heard about acute appendicitis, but acute appendicitis is not as common in us to actually be creating as much of a differential diagnosis. It's usually pain that starts in the epigastrium around the belly button, and if it persists for a while, the person feels anorexic, I don't feel like eating, develops a little bit, maybe a mild low-grade fever, also then associated with vomiting or nauseousness, and then when the appendix becomes inflamed, it radiates into the right lower quadrant. When the pain radiates to the right lower quadrant, that is where the issues start. The differential diagnosis coming to that point is based almost exclusively on what the patient tells us. That is why it's so important for us as patients to be able to tell our doctor, "Doctor, the pain started 24 hours ago. It started around the belly button. Since that time, this child has not been eating, has no appetite, and also has a low-grade fever." In addition to that, the pain is now much more severe around the right lower quadrant than it is around the belly button. Right away, the diagnosis of acute appendicitis becomes the first on our differential diagnosis. Not the only diagnosis, but the first on our differential diagnosis. And why does it become important at this stage? Because if the appendix becomes inflamed, then it can rupture. What does a ruptured appendix do? Now, that inflamed appendix, which from the inflammatory process produce a normal appendix, normal appendix that's become big and red and swollen. Now that red, big, swollen now develops into an abscess which forms a pus. Now you'll say, well, the pus then ruptures. What then happens? When that pus ruptures without diagnosing it and the appendix is not removed, that pus infects the entire lower part of the abdomen. Now, what could have been an easy procedure, which is making a very small incision or a cut over the right lower quadrant and removing the appendix before it becomes inflamed, now becomes a much more prolonged procedure in terms of opening up the abdomen much more in order to be able to remove that pus which has ruptured. That pus which remains there becomes a focus for pelvic adhesions. Pelvic adhesions are little fine collagenous material that can form, that can later present with intestinal obstruction. So that is why it's so important if a person, much more so commonly in a child, presents with right lower quadrant pain, we start to take it very seriously and have the physician evaluate it. A lot of times, however, that same appendix which is inflamed, either by a fecolate, which is a hardened portion of a stool, can disimpact itself once it becomes inflamed and the symptoms disappear. It doesn't mean your doctor's diagnosis was not right, but what has happened now is that you have benefited from nature itself, and now your acute appendix, which was then inflamed because it was the reason for the inflammation, the appendix itself was blocked, and it's a small blind-ended tube. Now, because of the fecolate or whatever is removed, now the circulation can resume. But it's to make the diagnosis, to treat it and treat it appropriately, that can prevent a long-term sequelae of a life with lower quadrant pain, especially in the younger populations. In our older population, right lower quadrant pain can be a significant finding, especially right lower quadrant pain associated with a swelling. Cancers can present that way, especially right-sided cancer, which can occur in the cecum. Here again, because the portion of the right lower quadrant, the cecum itself, is so large, a cancer could grow to an immense portion in that portion of the abdomen and presents with very few symptoms until it's extremely late. Other symptoms to do with problems that affect the small bowel, things like Crohn's disease, can also present with right lower quadrant pain in a younger population. So right lower quadrant pain in itself, when we're thinking of it, we should always be aware that things in the younger population, with the appendix being there, the working class population of the young adults, things like Crohn's disease, which are not uncommon in our population, but not as common as in some other populations, and in a much older patient, cancer of the cecum or cancer of the colon can also be a presenting complaint. That is all for now, ladies and gentlemen. Morning, ladies and gentlemen. Today we'll continue our discussion on abdominal pain and try and conclude the segment on the left lower quadrant pain. We've covered the different portions of the abdomen and the commonly presenting complaints and the ones that are most more common in our community in Richmond Hill. Left lower quadrant pain, however, is one of the other commonly presenting complaints that sometimes produces a lot of confusion in us. It's much more so in the elderly population. The left lower quadrant pain can involve the distal portion of the large intestine and also can involve the small intestine as well. If we look at this diagram, you can see where the portion of the large intestine, the rectum, and also the small intestine. Here is mentioned where we can have disease processes that occur within the small intestine, things to do with intussusception in a young child or in a young adult, things to do with ulcerative colitis and Crohn's disease, in the older population to do with cancers of the colon. But those are the things that only apply to the intestine. But other problems that can occur in the female population that can present with right lower quadrant or lower quadrant pain has to do with the genitourinary organs. And the genitourinary organs are basically the organs to do with the uterus, the cervix, the vagina, and also to do with the urinary bladder. So when a patient presents with left lower quadrant or lower abdominal pain, it in itself a very, very difficult diagnosis at times. And sometimes your doctor will keep asking you the questions back and back again, meaning, where is the pain? When did it start? How long has it started? Has it been the first time you're getting this pain? If you had it before, how was it treated? If you have it, how long does it last for? What are the exacerbating and relieving factors? What do you take when the pain comes on? What is it that can take away the pain? What is it that you've noticed that brings on the pain? Is the pain associated with any other symptoms? Is there a problem with the passage of urine? Is there a problem with defecation? Is there any evidence of blood in the stool? Is the caricature of the nature of the stool, is it narrowing this time? Is it change in caliber since? We also ask different questions. Basically, is there any discharge from the vagina? In the male patients, we ask urinary symptoms. Ask about urinary symptoms. Do you have a problem passing urine? Is there any evidence of blood in the urine? So the evaluation and treatment of lower quadrant pain in the population is very, very difficult at times. Sometimes you have to differentiate because there are 3 organ systems that actually converge on that area. You have the gastrointestinal system, which we've been doing series on over the last 3 to 4 sessions. And that can present with its own symptoms. But let's figure that out for the first time. If we say patients present with left lower quadrant pain coming from the gastrointestinal tract, in the much older patient associated with change in bowel habits, obviously we have to think first and foremost of colonic and rectal cancers, definitely, because those are the ones that are life-threatening. Sometimes when they present at this stage, and early treatment and resection of that portion, it can be life-saving. We also have to think in terms of the younger patient. Is this an early symptoms of Crohn's disease or ulcerative colitis? This is inflammatory bowel disease, even though not life-threatening, creates an increasing amount of morbidity at an early stage, meaning missing out on work tremendously, a sense of ill health and lack of well-being that sometimes prevents them from working. In addition to that, we face with the symptoms that do not arise out of the lower quadrant. Let's, for instance, figure that the kidney can also present with pelvic pain. Now, kidney pain not coming from the urinary bladder, but coming from the passage of a stone that starts in the kidney, travels down through the ureter, and now is in that distal portion of the ureter about entering the bladder. That in itself presents with a characteristic pain, extremely painful, so much so that most men will describe it as probably worse than childbirth, as if they've ever been through childbirth. So have a think of, when we think about lower pelvic pain, be prepared to spend some time with your doctor trying to diagnose where it's coming from. In the event of this, we may definitely need to do laboratory testing, as not simple things like just blood tests and x-rays, but in addition to that, things like sonogram and CAT scans in helping the diagnosis. But the important thing for us as patients is to realize we must come prepared, armed to describe to the doctor as many questions as he's probably going to ask you regarding this pain, because it's not a diagnosis that's easily made on physical examination. Most of that diagnosis can be made from the history and then confirmed by laboratory testing. And a lot of time, do not be prepared to leave the office with a diagnosis, because sometimes it's very, very difficult. And if you do not, sometimes the sonograms do not even show any evidence, but it can alter a good negative finding, meaning the absence of a stone in the kidney, the absence of a mass in the colon, the absence of maybe an infection within the urinary tract, is also a significant negative finding that is going to assist you in the further visit on how to be treated. That is all for now. Thank you. Ladies and gentlemen, we spent the last 6 sessions addressing issues to do with abdominal pain. I would like to recap and put it in a synopsis. Why is it so important for us to arm ourselves with as much information on abdominal pain before we see our doctor? Abdominal pain is such a common problem that we face with, and in each quadrant of the abdomen, some symptoms are much more common than others. For instance, the right upper quadrant, the gallbladder, the left upper quadrant and the epigastrium, the stomach, the right lower quadrant, the cecum, the appendix, the left lower quadrant, rectal cancers, inflammatory bowel diseases, Crohn's disease, ulcerative colitis, irritable bowel syndrome, and many others, diverticulitis, etc. Our aim is that none of us will be able to make all the diagnosis as patients before we see our doctor. Hence, when we go to see our doctor, we come prepared with the symptoms that we've been having. The things we can prepare is what is the history of the pain, how long we've had that pain. The nature of the pain, is it a colicky pain? Is it a pain that's constant? Is it a pain that is it radiating anywhere else? Is the character of the pain changed? Is the duration of having the intense pain changed since then, or has the pain become constant? Is it has to do with any exacerbating or relieving factors? What medications have we taken now? What we've taken in the past? Is there anything that we can identify in our dietary, in our foods, that has actually increased that pain in the past and now it's not working anymore? Our physical examination by our doctor obviously has to focus on, first of all, a general physical examination. You're looking at the patient's face. You're seeing, is that an ill patient or a not so ill patient, or a patient who is really experiencing an excruciating amount of pain? You can be able to look into the eyes of the patient. Are they pale? Are they anemic? Are they jaundiced? Are they dehydrated? You look at their tongue. Is it dry? Is it parched? You look at the cardiovascular system. Is their blood pressure low? Is their pulse fast? Are there any signs of hypovolemia? When you examine the abdomen, obviously you examine very cursory to look at where is this a generalized pain? Is this a localized pain? Which portion of the abdomen is the pain worse? Is it in the different quadrants that we've described? Is it anywhere we can localize the greatest intensity of the pain? Is the pain worse in some parts than other? Is the abdomen itself distended, meaning swollen? Is the abdomen itself has any discoloration, any abnormal marks suggestive of things like cancer that basically spread to the skin? Is there any evidence of basically trauma to the abdomen itself? You look at and you observe if the pelvic area, in a male, is there any testicular pain? In the female, is there any lower quadrant pain, especially over the areas of the ovary or the urinary bladder? You check the back. Is there any evidence of loin tenderness associated with kidney stones? Your next step is basically having done a physical examination. It helps you to narrow down your differential diagnosis as a physician. Then you can get onto your simple laboratory testing. Things like a CBC or blood count will show evidence of an infection, will show evidence of anemia. A basic blood test will tell us, is this a new onset diabetic? Is there anything to do with high cholesterol? Or any other factors, mitigating factors that can actually contribute to this? Is there the liver function? Is it increased? Is it not increased? Pancreatic enzymes, have they increased or not decreased? Is it the presence of blood in the stool? We'll check the urine, the presence or absence of an infection, presence or absence of blood in the urine. You can get a KUB, an abdominal X-ray. Is the abdominal X-ray showing evidence of air fluid levels under the diaphragm, which indicates a perforated bowel? Is it showing evidence of diffuse enlargement of the bowel, but not associated with fluid levels? Is there obstruction to some portion? Is it a large bowel that's enlarged? Is it a small bowel that's enlarged? Is it we find evidence of an enlargement of the stomach, so much so that there's no air in the rest of it? Is it associated with evidence of an obstruction in the stomach itself? Is there any evidence here that suggests the pattern of the small bowel to suggest any inflammatory process, infective process in which you find diffuse air fluid interfaces? Is there any evidence to show us presence of calcification indicative of stones, whether it be in the kidney or maybe even, if we're lucky, in the ureter? Those are some of the things that X-rays can help you, but they do not give you a diagnosis. Your differential diagnosis has to come from the patient's history, the doctor being able to elucidate from that patient the pertinent history relevant to what he thinks is the three most common causes of this pain, and then basically be using the laboratory testing, first of all, the blood test, the X-ray, probably a sonogram to show whether or not there's any enlargement or any stones within the gallbladder itself. Is there any stones within the kidney? Is there any enlargement of the kidney? Is there evidence of any pathology within the uterus itself, evidence of fibroids that can actually give diffuse abdominal pain as well? If those are not sufficient, we may end up having to have a CAT scan, a CT scan of the abdomen to see what else is going on. But none of these, an MRI is also indicated. Maybe an upper endoscopy to look into the stomach, or even a colonoscopy look into the bowel to diagnose the presence or absence of cancers, or an endoscopy, the presence or absence of cancers or ulcers. Also, in addition, a biopsy of the small intestine to make the correct diagnosis of Crohn's or ulcerative colitis, or even the absence of it to suggest it's irritable bowel syndrome. So the diagnosis of an abdominal pain, the correct diagnosis, is not a simple procedure. And sometimes you leave the doctor's office feeling dissatisfied that maybe you do not have the diagnosis. But at least at best you should have a working diagnosis for what you're being treated for. And if that pain should not be alleviated by whatever measures are taken so far, then there should be a contingency plan of having an admission to the hospital for evaluation. Here again, it's not a quick fix. because the hospitals will use the same procedures that the physician has used because they're run by the same doctors. Issue about that, it is not, but they have a much more higher technology available to them, but it is not to be used as the first means and method of diagnosis of any illness, much more so abdominal pain, which is a clinical diagnosis at best and confirmed by a radiological diagnosis in the absence of not being able to reach a diagnosis itself. Thank you, ladies and gentlemen. Good morning, viewers. This morning's presentation will be pelvic pain. Pelvic or low abdominal pain is that region of the body below the belly button that goes all the way down to the genitalia. It is that portion of the abdomen that sometimes presents with a difficult diagnostic problem for the clinician, and sometimes we can make life easier for ourselves and family by deciding when is it important to be seen by the doctor. Lots of us would have had kids who, prior to going to school or in the morning before going to school, complaining of lower belly pain. In the young female child, obviously you have to think about things like urinary tract infection. You also have to think about other things that could be infected the vagina itself by foreign bodies, depending on the age of the child and the behavior of the child. Also, in addition to that, we all know it can be used as a reason for not wanting to go to school. I'm not suggesting that basically we ignore those symptoms of lower pelvic pain in a child or a young child going to school up to the age of, say, 6 to 12, but also be aware that you can do a couple of things to diagnose that pain and actually be able to examine the lower abdomen of your child whilst distracting them and see if you can elicit the same tenderness and pain that they're complaining of. If, however, that pain is associated with fever, difficulty urinating, or actually anorexia or not wanting to eat, we have to pay attention to that pain, and that child should be seen by the physician, even if it's just for a physical examination and a urine test done. I do not suggest a pelvic exam at any cost. That should be something that's withheld at parental consent. The young female, teenager and young adolescent presenting with lower pelvic pain, the differential diagnosis, obviously at this point in time, will involve menarche or periods, or irregular periods, or in the older patient has to involve pregnancies. Now, let's take the young adult, the 14-year-old who's now starting the period. The periods can be, as we all know, irregular. It also can be skipping a couple of months and then recurring. But it also is very much to be aware that other factors can also present with those pains. If it happens to be a urinary tract infection, or if the person is sexually active, obviously things to do with infection within the uterus and the ovaries, the uterus and the fallopian tubes itself. Also, in addition to that, we have to look out for, in the older adult who is sexually active, look out for evidence of infection as a result of sexually transmitted disease, coexisting infections like urinary tract infections, which will present with more or less the same abdominal pain, here at this time being associated with urinary symptoms. The difficult cases come with a person with the irregular period to diagnose whether or not that pain is actually an emergency or an urgency. By an emergency, I mean if in fact it's not treated, can result in something that can be catastrophic. The case that arises is for a woman who has had irregular periods, a young woman, sexually active, who now has lower belly pain, increasing lower belly pain, probably more on one side than the other, and also associated with dizziness. We always have to consider in mind an ectopic pregnancy. An ectopic pregnancy is a pregnancy that occurs within the tube itself, and now there's no place for development of a fetus within a tube. If we look at this diagram here, what I'm trying to say is that if the pregnancy takes place within the tube itself, especially if you've had a previous infection, now there's no place for that to expand, and it ruptures and can cause sudden death, especially from the bleeding that it creates. So a young woman with pelvic pain who has a normal period, that is a surgical emergency, and the diagnosis is something that has to be made immediately. The diagnosis in itself is not a difficult diagnosis to make, if, however, you're cognizant of the fact that that is something that is an emergency. The issues to do in the older adults, the young adults here again we face with a urinary bladder, here the vagina from the infection, infections even within the uterus, infection involving the cervix, infection involving the uterus and the tube itself. Anovulatory cycles, which themselves, when you're not producing eggs, can produce an abnormal buildup within the uterus itself, which in itself, when the period comes by, is extremely painful. Also, the passage of an egg for that period of the month in the mid-cycle creates lower pelvic pain by the fact that anytime the egg leaves the ovary, it spills a little bit of blood within the pelvic cavity, and that creates a duration, a period of time up to 6 to 8 hours in which there is an acute amount of belly pain caused by the blood irritating the peritoneum. In the older adult, we face with a little bit more of sinister issues. When we look at the diagram involving the bladder, even not only things to do with urinary tract infections much more common in our older population, especially our diabetics. Also, in addition to that, we have to be aware that cancers of the uterus is much more common. Also, as we get older, we form benign growths called fibroids. Fibroids themselves much more common in people of color, can actually get large approaching our menopause, and as we experience menopause, they shrink in size. It is an extremely common thing to find fibroids within the uterus. In fact, as one study actually claims, 1 out of every 4 women will develop fibroids. Fibroids, or fibroids as we call them, can actually be growths that can become very large, cause the uterus to enlarge, so much so that it develops almost to the size of a pregnancy. The more commonly we find is that the fibroids within the uterus itself, either within the serosa of the uterus or within the muscle mass of the uterus. They can also occur outside of the uterus itself. If they reach very large in size, they can bleed heavily. They prevent your uterus from contracting at the time of your period, and hence you bleed much more heavily. In fact, a lot of women will tell you that they pass chunks of liver that looks like liver, based on a simple fact that sometimes these fibroids bleed excessively, or they prevent the uterus from contracting, so the bleeding becomes excessive. Here again, the diagnosis is not very difficult. Just by having a pelvic sonogram can actually make that diagnosis very easy. In the case of another cause of bleeding, which is much more sinister, endometrial cancer, a biopsy, a histopathological diagnosis has to be made by sending it to the lab. So abnormal bleeding and pelvic pain in itself should be taken in conjunction when diagnosis, whether or not this is a uterine problem, whether or not it's an ovarian problem. Much more uncommon is to find that the fallopian tubes are involved. A lot of times we also have to wonder whether or not that is referred pain, meaning pain that is coming from the rectum referred to the pelvic area. Here again, there's nothing short of a very, very important physical examination, both in terms of abdominal and pelvic, and also for your physician to take a proper history as to the nature of the pain. That is all for now. Good morning. Over the last week in my private practice in Richmond Hill, I've realized 2 very important lessons. How important it is to actually be able to make the correct diagnosis and to be aware of common things are common. In both of these cases, it had to do with pelvic pain in 2 women, one a young woman of childbearing age and one an older woman. Let's take the scenario of the younger woman, sexually active with lower pelvic pain. From my history, I gathered that she was sexually active from the age of 18 and had difficulty getting pregnant. The difficulty was due to the fact that she developed something called pelvic inflammatory disease, which is basically a very common infection involving the uterine tubes. They're actually an infection that's transmitted up the vagina during sexual intercourse and basically results in blockages involving the tube. In this unfortunate case of this young woman, what had happened is that basically her fallopian tubes became infected, and hence she developed an infection of the tube and then developed a tubo-ovarian abscess. The tubo-ovarian abscess was treated about 2 years ago when she presented at the hospital with pelvic pain. In addition to that, she was adequately treated and the pain disappeared. She would experience pain at the time, different times of sexual activity. The more sinister thing for this young woman who recently got married was that she became pregnant. The issue about her pregnancy, the tube in itself that was infected, and it's usually both tubes that become infected. Had difficulty getting pregnant because the uterus itself became infected, which is this portion here, but then the tubes became infected. She got pregnant and the pregnancy was in the tube itself. The pregnancy was in the tube. She started to experience abdominal lower pelvic pain. She also became dizzy when she started to bleed. She went to a physician. She was not diagnosed in the first place that she had an ectopic pregnancy, meaning a pregnancy that is outside of the uterus. That pregnancy itself grew, and about 6 weeks it ruptured. Fortunately for her and her husband is that basically she was smart enough to rush, call 911, get to the emergency room. When she got there, she was pale, she was diaphoretic, she was bleeding excessively from the abdomen. They managed to transfuse her, stabilize her, went into the abdomen, remove the pregnancy in the tube itself, which was about 6 to 7 weeks. Actually saved her life by removing that portion of the tube. The unfortunate sequelae with this was that an activity 2 or 3 years ago when she was much younger resulted in an infection. Now it's very, very unfortunate. She probably will not be able to get pregnant again, because any future pregnancy will also result in an ectopic pregnancy. The two big lessons about this was that is to be safe in terms of sexual practices, but in addition to that, to be careful in terms of a young person who's missed their period, had a previous infection within the tubes, or pelvic inflammatory disease, or even just an endometritis, to actually be aware that pregnancies in the tube can be fatal. In this young lady's case, she managed to survive and she's much alive and well. Issue with that possibility of pregnancy is almost going to be zero. The other case in question was that of a much older woman who had been seen by a physician for about 5 to 6 years prior to that and was told that she had evidence of fibroids. I mentioned to you in a previous talk that there are other things that can occur that can cause pelvic pain that arises out of the uterus. Fibroids in themselves are, by and large, the most common. You can get a fibroid on the outside of the uterus, you can get a fibroid within the walls of the uterus, or even within the endometrium of the uterus. These are quite common. They will tend to bleed excessively. They will tend to cause pain as they get larger and outgrow their blood supply. Hence, you can experience, even the woman who's having her periods, very painful cycles, very large amount of bleeding during those cycles, based on several factors, whether it be the size of the fibroid itself, or in addition to the failure of the uterus to be able to contract. Here again, this becomes a vicious cycle. If your periods are very heavy, in excess of the 50 cc's of blood you're expected to lose every menstrual cycle, and you start to lose 250 cc's of blood, when you start to not being able to use a couple of pads to 3 to 4 days, it goes on to more than 3 to 4 days to a couple of weeks, or you start having to use cloths. Then you check your blood and you find that your blood count is low. Those are indications that the fibroids need to be treated. If you're a woman or who is requesting childbearing still, a myomectomy or removal of those fibroids is probably indicated. For a woman who is not childbearing and has fulfilled or childbearing obligations, then a hysterectomy is not at least a bad procedure. Removal of the uterus and probably ovaries and the tubes at the time, and get replacement hormonal therapy. The issue with this elderly woman, or this older woman, was the fact that her diagnosis was always made of being fibroids. It turned out that she had fibroids, but she also had coexisting endometrial cancer. The cancer continued to grow while she continued to have the diagnosis of fibroid being made. If in the event of you going by your doctor and figuring out that endometrial, you're actually being diagnosed as fibroids with heavy bleeding, my suggestion is that you definitely have an endometrial biopsy. You need to have a dilatation and curettage and basically be able to biopsy whatever lesions within the uterus just to make sure that there's no evidence of endometrial cancer. The earlier you catch endometrial cancer, which by and large is a slow-growing tumor depending on the degree and the type, by and large it's slow-growing, but if caught early, you can actually have a cure. If, however, it's metastasized or spread outside to the uterus or even contiguous spread to the cervix, then it becomes a much more difficult 5-year survival. In fact, the life expectancy is decreased significantly. The two suggestions that I have for these two cases, with the elderly person or the woman approaching menopause, is that that's between the ages of 40 and the 60 spectrum. Be aware of diagnosis of fibroids if they are very common. If you do not get the relief that you're looking for, at least have a biopsy done for it. Make sure it's not endometrial cancer. For the younger woman with an irregular period, it's basically to make sure that that you do not you use protection at all times and avoid things like pelvic inflammatory disease at all costs, but also be cognizant of the fact if you've had an infection before, pregnancy in the tube can be life-threatening. That's all for now.